Dr. Helen Leonard from Perth, Western Australia, and I manage the International CDKL5 Disorder Database, and I'll be presenting some data that we've collected there, and I'll be followed by Dr. Raj from Los Angeles. Thanks very much. So we're talking about anti-seizure medications, past, present, and future. And these were our... So, I'd like to start by just telling you all, some of you will be well familiar with it, but for those who are not, a little bit about the International CDKL5 Disorder Database. Now, as Dr. Pestana Knight introduced this morning, it was in 2004 that mutations in the CDKL5 gene were found to cause a severe neurodevelopmental disorder with infantile spasms. Now, the two girls that you can see pictured there were featured in that article. And that is the Australian family where these two twin girls were both affected by CDKL5. But they're quite different. The one on my right, she has typical CDKL5 and was originally diagnosed as atypical Rett syndrome. The one on the left has a mild form of autism. She has no seizures and she can verbally communicate very well indeed. So that was my introduction to CDKL5. And up until about 2010, 2011, we have been collecting information about cases of CDKL5 in our International Rett Syndrome database. So at that time, we decided to compare the characteristics of those with a MECP2 mutation, those with typical Rett syndrome, with those with CDKL5. And we found quite distinct differences, as you probably all know, that the seizure started much earlier in CDKL5, usually within the first 3 months of life, and nearly always within the first year. There was also no period of normal development as in Rett syndrome. There are other differences as well, but I won't go into them in detail now. But over time, it actually starts, it includes the cases that were recruited in the international database prior to 2012. And then from 2012 onwards, it was straight into the CDKL5 database. And you can see the distribution of ages. And now we have a large percentage under 2 years at recruitment. And this ties in what we were saying earlier, the age of diagnosis is falling rapidly in CDKL5. And on the pie graph at the top, you can see the different countries are represented. The USA, Australia, we've got a big group from Russia, UK, Canada, Germany, France, Brazil, Japan, and Italy, and other countries as well, which have smaller numbers. So now I'll move on to what the topic for, now that you know the background to the database and how we collected the information, I'll move on to the topic, which is anti-seizure medications in CDD. As you all know, epilepsy in CDD is severe and often includes multiple seizure types, most common being spasms, tonic seizures, and generalized tonic-clonic seizures. There is some relationship between the CDD variant group and the frequency of seizures in individuals. Reduced seizure frequency has been shown to be associated with better functional ability, including independent walking and expressive communication. But as you all know, and we've alluded to today already, treatment of seizures in CDD is complex, often requiring multiple therapeutic agents, which often have a short and temporary period of efficacy before a return to baseline of rebound seizure activity. And I expect many of you have experienced this, unfortunately. So this was our most recent data on seizures. We showed that about 30, this with children aged 3 and over. 13% were seizure-free, 27%, just over a quarter, had less than 1 seizure per day, 30% had 1 to 4 seizures a day, and another quarter had 5 or more seizures per day. So it's a considerable burdensome condition. So the purpose of this study was to describe the benefits of different anti-seizure medications as perceived by you, the caregivers, and to describe the frequency of side effects that you noted. So what did we do? We used the caregiver responses to questions about current and past medications. And for example, for past medications, we asked caregivers to complete the following table on the anti-epileptic medication their child had taken in the past. Dosage, if they could remember, age started, age ended, side effects, and perceived benefits for their child. So you can see here this table, and this family had completed it very well. They didn't know the dose, but that's all right. So they'd given us the age started, the age ended, the side effects, and the benefits. And some of you may be familiar with this if you've completed the questionnaire. So what did we find? We found that in general, the children and adults had used 23 unique different anti-seizure medications. That's not one child, all over 23 different unique medications. Approximately half took 1 to 3 medications in their first year of life. A smaller fraction had taken 4 or 5 in their first year of life, while 8% had used at least 6 medications in their first year of life. In terms of lifetime use, most individuals used 2 to 5 unique medications early in life, and the number gradually increased to 6 to 8 by adolescence. So the top 5 ASMs most frequently used were levetiracetam, Keppra, Topamax, Depakote, Sabril, Phenobarb, or Luminal. Are you familiar with these proprietary names? Yes. Oh, that's the US ones. I did have, you got the wrong slide, I did have the names for the least used medications, which were Fycompa, Felbitol, Zerontin, Mogadon, Gabapentin, Crazipate is Tranxene, and Salsiam is Oscol. But they were the ones that were least frequently used. So this table here shows the age of first use and the duration of use of those which were started in the first year of life. And the one that was started earliest was Phenobarb or Luminal at the age of 2 months. And remember, this is going from 2000. Some of the families filled out the questionnaire in 2012. So it was a long time ago. And the Phenobarb was continued to use for 73 months. Next was Keppra, started at a median age of 5 months. And then Klonopin at a median age of 7 months. But Depakine at a median age of 8 months. Topamax at a median age of 9 months, and Sabril at a median age of 9 months. So that was the age of onset of those who had started their medications before the age of 1 year. So just to summarize that, because you may not remember, the Phenobarb, that's Luminal, was started earliest at a median age of 2 months, median duration of age of 73 months. And this group here are the most used medications, over 100 uses in the database. Keppra at a median age of 5 months with a duration of use of 31. Clonopin at a median age of 7 months with a median duration of 24 months. Steroids at a median age of 8 months, which with median duration, I think that is incorrect, it was shorter than that for steroids. Depakote at a median age of 8 months with a median duration of use of 9 months, and Topamax at a median age of 9 months. So examples of medications which were commenced after the first year of life were Zonogram, first used at a median age of 21 months with a duration of 25 months. Lamictal, first used at a median age of 21 months with a median duration of use of 31 months. CBD, used at a median age of 26 months with a median duration of use of 19 months. Benzo, at a first use at 33 months, and Fycompa at 67 months. Now the medications which were started later are newer medications, so the children were probably older, and that's the reason why they were older when they started these medications. And this just shows you that in graphical form. I'll flip through it. Lamictal 21, CBD 26 months, rufinamide, benzo 33 months, Parampel, Fycompa at 67 months. Now this is an interesting slide. It shows you the likelihood of any seizure-related benefits and any side effects associated with the use of anti-seizure medications. So the one on the left, on the far left, is CBD, funnily enough. So that was one that families rated best and with the fewer side effects. The second one is Fycompa, which had good rating but had more side effects. The third one is Sabril, and the fourth one is Lamictal, and then Clonopin. So as you see, the blue is good, that's the benefits, the red is bad, that's the side effects. So we're trying to work out which was best overall. So just to summarize that here, CBD was reported to be highly beneficial. 80% of responses reported improved outcomes with few worsening, and side effects weren't bad. Similarly, Sabril, Gepakine and Lamictal were beneficial in more than half of the uses and fewer than a third reported side effects. Not shown on the graph was any worsening of seizures, was only reported for small numbers, but included transine, what was that carbazine again? Oh, it's carbazine. Sorry? Trileptal, Lamictal and Topamax. So they were the ones where families reported worsening seizures. Despite their widespread use, Keppra and Luminol had lower likelihoods of benefit, and Luminol, phenobarb, had a much higher probability of side effects. When we wrote our paper, we discussed this. We wondered why they had been continued so long, and one of the neurologists suggested it was because they were concerned about withdrawal symptoms if the phenobarb Luminol was stopped. And I was surprised at that because it didn't seem to be that beneficial. So in the next slide, I'll show you the likelihood of any side effects and benefits of some dual and triple therapies. And we found, and I'll show you this in a minute, the ASM combination with the greatest benefits and fewest side effects was sodium valproate, that's Gepakine, and Keppra, followed by Sabril and Clonopin. However, for the numbers for each combination were small. I was surprised that the numbers were so small, but when you think about it, there are so many drugs and so many potential combinations that it ends up that there aren't that many for each combination. So you can see on the first one, which is valproate and Keppra, with a lot of blue and not much red, then Sabril and Clonopin, and then Keppra and that's zonisamide, yeah. So, I mean, the idea for this study was that we'd find some magic answer, that we'd find one combination that was so much better than anything else, but we didn't really find that. But we're showing the results as they were.
But you did find one that doesn't have any side effects. Which one was that one?
Oh, no, fewer side effects.
The one that doesn't have any red.
Oh, yeah, that's right. That's true. That is Sabril and zonisamide. Yeah. I think that was is that the combination from the Georgia study? Do you remember? It was zonisamide, it might have been that one. There was a study in Georgia of 5 patients, and it included zonisamide, and they said that was very good. So I'm not sure whether that was, it was certainly, I can check that for you. Yeah, that's true. Thanks for picking that up. So, this is probably what you actually know, but the top reported side effects for individual anti-were fatigue in 16 out of the 23 ASMs. And the ones where it was highest were clobazam, Omphy, phenobarb, Luminal, clonazepam, Klonopin, and Fycompa, perampanel. So just to go back to that, this is exactly what we were talking about this morning, that it's actually, it's quality of life, and if the fatigue is so bad that the child's asleep all the time, you have to wonder, whether the medications are worth it. But Dr. Raj might talk further on that. So some issues regarding our data. This is the largest collection of data on CDD, thanks to the contribution of families worldwide and you people here today. It's really important, because otherwise we just wouldn't know so much about CDD. However, we didn't have information on the exact seizure type presenting when a new medication was introduced. Nor did we have information about the exact seizure frequency before and after a new medication was introduced. But we do know whether the family told us whether it was beneficial or not. We started collecting data in 2012, and so there have been some changes in anti-seizure medications over time. And I mentioned that some of these new medications have only recently come on the market, and therefore the children were older when they were started. This is an international study, and there are variations in which anti-seizure medications are available in different countries. So you might find different patterns of prescribing according to the country. So in an attempt to make any recommendations about different ASMs, we considered the likelihood of benefits and side effects. We also looked at the duration of use, because we thought that when continued for a long time, that's probably an example of its acceptance tolerability. So of those commonly used by greater than 100 individuals, Depakine and Lamictal were those with the greatest benefits and least side effects, with a current duration of use of greater than 30 months. Topamax and Keppra were slightly less beneficial, although they had similar durations of use. And Depakine and Keppra was the combination therapy with the greatest potential for reducing seizure activity relative to side effects. So more time and more data, which I hope you people will contribute, are probably required for assessment of newer anti-seizure medications like ganaxolone. Caregivers did rate CBT very highly, and one recommendation would be to conduct a randomized control trial to further investigate it. It is clear that the relationship between epilepsy, the side effects of ASMs, nighttime sleep disturbances, and daytime sleepiness is highly complex and challenging to unravel, especially since daytime sleepiness is associated with poorer quality of life. So I'll now pass on to Dr. Raj.
We'll continue with another one of our papers in which we looked at infantile spasms specifically. And in this study, headed by Dr. Olson, we had 59 children with CDKL5 who had spasms, and 27 of those were treated within the first month of spasm onset. So got to pretty early, got treated early with first-line medications, ACTH, prednisolone, or vigabatrin. 7 out of 27 were spasm-free at 2 weeks. So a modest response to these first-line medications. But what is a little bit disheartening is that 1 out of those 27 kids were spasm-free at 3 months. So they responded to medications initially for their spasms, but at 3 months, only 1 out of the 27 were still spasm-free. Of note, the ketogenic diet, when used within 3 months of spasm onset, has sustained remission at 3 months, 2 out of 13. So, some of the positive minuses that we saw in the studies that the ketogenic diet used early on could be a potential benefit for infantile spasms. But one of the disheartening things that we saw was that, compared to other kids who didn't have CDD, they responded at a less rate, so 26%, and 1 out of 27 were spasm-free still at 3 months. And a lot of families could kind of probably corroborate that even though they responded initially, antispasms returned within time, which just puts more focus on that we have to find better first-line treatment options for infantile spasms, especially in our CDD population. So for the present, we're going to talk about anti-seizure medications, touch on surgery, diet, and devices. And these are kind of our frontline treatments for CDD. So these are the anti-seizure medications available for epilepsy. And if we go back to phenobarbital, which is 1911, I think, or this graph ends at 2020. Ganaxolone was afterwards, but you can see that there was from 1930s to 1960s was the first generation, and then second generation, and then about the 1780s onwards is the third generation drugs. So a lot of these medications are familiar, but I think some of the art with medicine is figuring out which medications are effective, which aren't, and being kind of specific and tailored for your child. To touch on Ztalmy or ganaxolone, this is the first FDA-approved drug for CDD. Raise your hand if you've been on Ztalmy or tried it. Okay, so a lot of families here. Any families who have tried it and discontinued it? Okay, good amount of hands too. So median percentage change, and this is in the study of ganaxolone versus placebo, and this was 101 kids internationally. They saw a seizure reduction about 31%, so let's say from 10 seizures a day down to like 6 or 7, compared to placebo, which had a 7% seizure reduction rate. So you can definitely see there was a difference between the people who were on the drugs versus placebo, and about almost a third had seizure reduction in the trial. At the same time, when you think about medications, we always think about side effects. And the treatment-related adverse events, the most common one was sedation. 34% in the study versus 6% in the placebo. A couple kids had supposedly increased seizures on placebo as well as the drug, whether that was the CDD itself or just the medication's hard to tell. Constipation was a little bit increased. Sedation, which is similar to somnolence, and salivary hypersecretion. So pretty common side effects that you can see with seizure meds, we did see with Ztalmy. Next, so surgery. This is one procedure, is the corpus callosotomy, and Dr. Weisenberg, who's here, she's giving a lecture specifically on surgical options for CDD and for intractable epilepsies. But corpus callosotomy is effective in drop seizures and generalized seizures. The corpus callosum is this highway that connects both hemispheres of the brain. And by disconnecting that pathway, you can help try to reduce seizures. I would say it's a palliative procedure. It's meant more to try to reduce seizures and try to improve quality of life, and not the classic kind of cut out a part of the brain to stop the seizures totally. But Dr. Weisenberg will go more into that. Anybody here who had surgery or corpus callosotomy? So a couple of hands. Next is the diet therapies. So how about the ketogenic diet? Raise probably the most hands so far. So there are kind of three mainstay diet therapies. So one is the ketogenic diet, which is the most strict in terms of diet therapies. The next one is the modified Atkins diet, which has a little more flexibility. You don't have to weigh the food and measure it that way. And then the one with the most flexibility is a low glycemic index diet. And if you want to hear more about the ketogenic diet, the Charlie Foundation is an excellent website to give you kind of recipes, diet, information. So the classic keto diet is a high-fat, adequate protein, low-carb diet. And when I say high-fat, 90%. And when I say low-carb, I mean 2 grapes, like 2 individual grapes, or half a slice of bread. So the classic keto diets can be definitely effective in our CDD kiddos who have G-tube and are able to receive a kind of ketogenic diet formula straight to the G-tube, but and you can also do definitely keto by mouth as well. Modified Atkins is a little more liberal, but it's only liberal in terms of amount of protein and less fat. And then low glycemic index is probably the most liberal. I think the ketogenic diet is a great option outside of medication. I think we often don't try it early enough. I would say it needs constant supervision with a dietitian and neurologist. The goal is to be very ketotic usually when you're on the ketogenic diet. A lot of families try to do the diet on their own, and sometimes it's hard to know what has sugar, what doesn't have sugar, which diet is giving you enough calories. You have to be very well hydrated. There are vitamins that if you're on the ketogenic diet, you won't get. So you have to do additional vitamin supplementation because your regular diet, you're not receiving it that you would receive in your regular diet. So there's kind of lab work, close monitoring with the keto diet. And I would say at least try for 3 to 6 months. I think that's a good kind of benchmark. If you're on the diet for 6 months, you're not seeing any benefit, then maybe we can consider switching it. But doing it for a shorter period of time, you might not see the benefit as easily. And I would say breaking the diet is kind of like skipping medication doses. So that has to be kind of an investment from the entire family because it definitely is a lifestyle change. So devices, there's 3 devices that I can talk about. So and all this is kind of very much off-label, but the vagal nerve stimulator over here is the device that's placed underneath the skin. The wire goes up to your vagus nerve and it goes up and stimulates the brain to try to prevent the seizures from coalescing and letting this abnormal activity come together. So the device sends a signal throughout the day, just trying to break up your brain's ability to cause seizures. Can I get a hands for a VNS device? Okay. So less than keto, but more than surgery or corpus callosum. Okay. The RNS device is this device here, which is actually placed on the brain or placed in the skull cavity, and then it has an electrode that goes into areas of the brain. And what those electrodes do is kind of like they're EEG electrodes, and they measure abnormal activity. So the device records abnormal EEG activity, and if the activity captures seizure activity, it will send a signal to try to stop the seizure from happening. So it's a little different than the vagal nerve stimulator, which just constantly sends signal. It's a kind of open loop device, but the RNS is responsive. It has EEG data, and then it stimulates, and then sends a signal back. So it's a closed loop or responsive. The last one is the DBS device, where again you put a device underneath the skin here, and you put the electrode in deep in the brain, usually the thalamus, and it sends signals to try to break up the seizure activity too. But the deep brain stimulation doesn't have EEG recordings. It doesn't respond to what the EEG is showing. So we published this recently in one of our journals where this is not for CDKL. We didn't have any CDKL5 kids in here. This is a little bit, very much off-label, I would say. So RNS is approved for ages 18 and above, but this is for pediatric onset kids. So we had 16. 6 patients were younger than 12. And we put the electrodes in the thalamus. So the thalamus is kind of the relay station for where seizures can pass through. So usually your seizures start from the surface of the brain, and it goes deep through the thalamus, and then it'll spread to the rest of the brain. By putting this RNS device in the thalamus, we try to kind of shortcut the travel as it goes through across the brain. And when you put the electrode in, it will record seizure activity, see the activity, and then stimulate trying to stop the seizures. So 10 out of 16 experienced less than 50% seizure reduction, which is very good. A limitation, so it was a small patient size. This was not a randomized controlled trial. These families knew they were having this very large surgery. And the family reported the seizure count. So like drug trials, we rely on families to tell us how many seizures they're seeing before and after. The device itself does not count seizures. I wish it did, because then I could just scan and say, okay, the device is telling me that you have this amount of seizures, but it doesn't do that. It just captures that abnormal activity. Clinical trials, so the GEM study, which is now currently recruiting, is one of the trials that's open. That's the drug fenfluramine or Fintepla. Has anybody tried Fintepla or been part of this study? Okay, not part of the study, but trying Fintepla. Okay. And then we have the Ovid Takeda phase 2 trial, which was completed. I know we have any other families with Ovid Takeda? So that was a phase 2 trial. So it was where they tried the medication with CDKL5 and Duke15Q. Some of the people on the CDKL5 board, they were part of this trial, and they can give their information as well. And then the third trial is this Longboard Pharma Pacific trial. So there are always opportunities where companies are trying to focus specifically on CDD, which I think is important because it highlights the community, but also we're looking to see if the drug specifically works in this population. So as opposed to a lot of drugs which are applicable to multiple indications, this is really trying to see, hey, does your drug work with this specific mutation? So what is our future? I think newer, more effective medications with less side effects. I have an interest in kind of the brain-gut axis and connection, and whether we can do something with the microbiome, whether it's kind of prebiotics, probiotics, and whether we can change the diet and improve things so the brain-gut axis improves. More effective devices. The clinical trial readiness study, which is the NIH-U01 study, trying to measure things correctly and try to figure out whether our newer studies and our newer gene therapies are effectively capturing change. And of course, gene therapy is kind of the future that we hope to inspire for. And I will say the future is bright, so bring your shades. This is my patient Stella out of LA, one of my superstars, and that's her at school on this way. So, her mom sent me this picture a couple days ago. Thank you, everyone who's submitted data to the database. This is funding and support, and thank you, everyone.
Does anybody have any questions for Dr. Raj?
Please.
I do have a couple of questions, but I don't know. One of them is about surgery, and I know you said that there's a talk about surgery coming up, but I am wondering, since we're waiting for these therapeutics that are hopefully disease modifying, how advisable do you feel it is for a permanent treatment option to be undertaken right now, given the state of our kids?
Sure. I would say I would take into account how much the seizures are affecting their quality of life. Because if you feel like medications, the other treatment options aren't helping, then I think if surgery is advised to you by your treating team, then it might be worth considering earlier on. When you bring up disease-modifying therapies, usually it's hard to know, to be honest, whether the companies would exclude your child because they've had surgery. I would think that's probably unlikely because there are other kind of treatments where you don't exclude surgery beforehand. But I can't guarantee if a company would say, oh, just because your child had surgery.
I'm more worried about permanent side effects of permanent treatment options, right?
Oh,
You can't roll those back.
Sure. Oh, okay.
That's what I was.
That's true. It depends also what kind of surgery you're having too. So, yeah.
I was also wondering in terms of, so I don't live next to a center of excellence, and our neurologist is wonderful and we love him, but he isn't doing kind of current research into CDD, so I'm more the one who informs him of these. So I'm wondering, how do you use all of these findings that you guys have presented? And by the way, I would love those slides of the medication, all of those I would love to present to my neurologist. But how do you use these findings to inform your clinical care now? So what we're waiting for is fantastic and very hopeful, but what we have now is what we have now. So how do you use these specific findings about CDD to inform your clinical practice when you're also a general neurologist who knows about all kinds of AEDs and other treatment options? How do you apply them to our very kind of unique kids?
Yeah, I'm from UCLA, and I think the benefit of the Center of Excellence is that, CDD is my passion. I'm really involved and trying to help the community and really try to do as much as I can. I think I get a lot of families out of state, and whether I see them like once, and then if I have recommendations, I'm happy to talk to the local neurologist just to kind of convey my thoughts. Say these drugs might be helpful. These drugs might not help as much, or they've been on this drug and I don't, based on our data, I don't know if it's really going to help. Maybe come off that one and try to be helpful as you can. It's hard, writing prescriptions and stuff like that for people out of state because I don't have the state license, but
Sure.
I'm always happy to talk to your local neurologist, and then usually people just email me and we email back and forth and kind of spitball about things.
Yeah, I think I was more wondering about, is there any decision tree in your mind of what should I start with, what kind of category, or what is the thing that I'm going to try first, or what is the order in which I'm going to go?
Yeah.
Those kinds of things that are kind of trial and error.
Yeah, it's very much based on the family. I have one family who doesn't want to do any medication, and they do say the side effects are worse, and they'd rather just kind of try different things, and I don't push medications. I say, if you don't want to do I'm not going to force you to do medications. If the seizures, can be life-threatening, and we have that discussion and have your rescue meds and stuff like that, and kind of have a plan. And when things go bad, they email me and say, things are looking bad, I want to do a medication now. But I'm not the person to say, we have to do this or do that. It's more a conversation.
And the other thing is about the work I've just presented. We've submitted that for publication. So it should be, assuming it's accepted, then it will be available for all people, all neurologists everywhere. And you can point them to this data, and they can look at it in relation to their own patients. So that's why we try and publish, to spread the word.
I can't wait for that.
Sorry?
I can't wait for that.
Yeah,
I think that'll
yes.
be exciting. And I have one last question
Please.
about how you think about number of AEDs. We just ran into this recently where we're on an AED that doesn't actually do anything for seizure control, but we realized that it's the thing that helps my daughter sleep through the night. It's just, it's been wonderful, but we didn't realize it was that until we tried to wean it, thinking it's not doing anything for seizures. And then we had like 36 hours of no sleep. We got it back on. She slept through the night. So our neurologist, because I was concerned about how many AEDs we're on now that we can't wean this one, and he said, well, but this isn't really counting as an AED anymore because it's not doing anything for seizures. True, it's not doing anything for seizures. It was useful for me to reframe it, but it's still an AED. So how do you think about that when you think how many AEDs is a family on? How many do I want to add? Should I wean one? Do you think about ways in which AEDs are used by a specific family for other uses?
Yeah.
And does that count for you in terms of treatment?
I would, a
And
lot
how
of
many you allow?
medications have kind of dual purposes, so, if I'm doing Valium to help with seizures, but I do a higher dose at night to help with sleep, then I consider it anti-seizure medication because we're trying to help seizures, but it could be doing a lot for sleep at night. So, for me, I don't kind of go in that, this is for seizure, that's for sleep, unless I need to. Let's say if you're doing a trial and you're like, how many seizure meds you're on, then you don't have to really kind of delineate. Usually if medications haven't been helpful, and I try to remember and check my notes, and the family usually tells me, hey, I've been on this medication since 10 years ago, and we're still on it. I don't know how much it's helping. I say just let's get rid of it, and then come off it slowly. If you see seizures come up, if you can fight through it and try to see if it's just this period where seizures are returning, we'll continue pushing through. But if seizures get really bad and the this medication after 10 years definitely was doing something, then we put the med back on and we try to come off something else.
Have you ever had a situation where you put somebody back on after you tried weaning and you didn't achieve the same results that they had?
Rarely. It has happened, but for the most part, we can regain it.
Thank you.
Yeah, please.
When you study the effect of all medicines, do you also take in those who don't medicine with children? It would just be interesting to see the ones who kind of give up medicine, how many seizures they have compared to those. Oh, no.
I didn't hear that one. I'm sorry.
Sorry. So do you ever compare the ones who take their children off medicine, so the ones who don't use any medicine? Do you compare those with the number of seizures with the ones taking different medicines?
So,
because I just read on the Facebook group, there are some cases where they say, nothing works, so it's better off.
We could probably look at that in our data.
Yeah.
We could
It'd
probably
be very
do that.
interesting to see if it's...
it's hard to, because we have such small numbers of people who aren't on meds, I would say, the very few that I don't have meds have a good amount of seizures. But that's the family's decision, and kind of that's the conversation we have. But I would say that they do have good medicine. Yeah. So it's really kind of a conversation. Yeah. Yes, please.
For the registry, is there something about quality of life? Is there a specific questionnaire, validated questionnaire that the parents are answering?
Yeah. If the in the follow-up questionnaire, the QI disability, which you had about this morning, is used, and we did do a study, which I think Dr. Castano and I presented, where we looked at the factors that were affecting quality of life, and polypharmacy, more than 3 medications, was something that adversely affected quality of life. So in any follow-up questionnaire, we include quality of life. Yeah.
And it was a specific. You said which questionnaire was it?
So in the ICD, everybody completes a baseline questionnaire when they recruit. And then in 2018 to 2019, we administered a follow-up questionnaire to everybody we were able to contact. And we have subsequently administered another follow-up questionnaire, but we should really do another one because the time period is extending, and in that follow-up we collect information about quality of life. Yeah. So we have a paper about the factors affecting quality of life, and polypharmacy, more than the actual seizure frequency, was the one that affected quality of life. You can see our website there on the slide now. Anybody who hasn't joined the database, we would be really grateful if you could go to that link and register. And if you would like to complete a follow-up questionnaire and haven't heard from us, again, email me at my address.
Yes, please.
Backing up to surgery options, my kid has a VNS. Are the surgery options able to be used in combination with each other? You know, we have a VNS, are we still eligible for the other options?
Correct. So depending on where your institution, sometimes having a VNS can affect your ability to do MRIs. So that, for surgical planning, that might cause some difficulty, but you're still eligible for any other surgical options, correct?
Okay. Do you know, because they talked about the brain catheter possibly being a form of treatment in the future, would the surgeries that are currently available affect possibility for the brain catheter in the future?
So I think you're talking about the gene therapy, about
Yeah,
whether
yeah.
the catheter to administer the drug. I don't know if that would affect the future because the companies themselves kind of decide why certain people get included or excluded.
Mm-hmm.
So I don't know if anybody has any other kind of data on that, but it's really kind of based on what the company is comfortable accepting into their trials.
Okay.
Yeah.
With the placement of the RNS, is that something that could be removed? Or once it's in the brain, it's there?
No, it can be. It's an invasive surgery, but you know, you open the skull cavity, you put a device in to electrode the brain. It's much more invasive than the VNS.
But just kind of piggybacking off the question, if there were an avenue to do a cannula, the intracranial cannula, you could remove the previous device potentially.
Can it be an SP removed?
Yes, so but you can't remove all of it. So you can remove the generator, the battery, the wire that goes up to the vagus nerve, but then there's like a coil that wraps around the nerve. It's very hard to take off that coil because you can damage the nerve itself. So our surgery removes like 95% of the device. The families who felt like their VNS never really helped or they didn't find it effective, you can just turn off the VNS or let the battery die out and you just have a device left in like a pacemaker. Any other questions? Yes, please.
Excobrate, has that been a known drug for CDD? Or is that just a typical epilepsy drug?
Excobrate or cenobamate is, do we have any kids in there?
No, I don't think so.
Yeah, so it is an anti-seizure medication that's FDA approved for Lennox-Gastaut syndrome. I've used it off-label for CDD. It's an anti-seizure medication that can be used.
Does it interact with any other medications?
There are some interactions. There are some interactions with clobazam and other meds, but it's definitely an option. This is all off-label. I don't even know what age it's approved for, but you can.
My son's 20,
20, yeah.
and he's
So,
just recommended
Excobrate.
to excobrate.
Sure.
But he's also on the Steripanto and Trileptal.
Yeah. So there are some interactions, but definitely. It's nice to see everyone.